Hanji everyone, good evening to all the dear students. And although I have already done a recall in the mega recall session, and I have also shared the answers in the form of very shorts and reels. Here I would be doing a quick recall of OBGYN NEET PG 2025, and so don't worry, it's not going to take up a lot of your time, but yes, you've been asking for it and we are here. Okay, so let's look at the first question. So this was one of the image based questions which we also covered in the marathon, right? And what is the image showing you? Right, so this is an image of controlled cord traction. It was not an image of MRP, I am 100% sure. So this was the image, and this is controlled cord traction, something that we do in AMTSL, right? The other name for this is what? Jaldi se batao. Yes, it is modified Brand-Andrews method. Yes. So modified Brand-Andrews method of controlled cord traction, right? Where one hand is pulling the cord down, the other hand is giving a counter traction to the uterus in the upward direction to prevent uterine inversion. Okay? Yes, perfect. Let's look at the second question. Okay, so this was again an image based question and we covered it in marathon session as well, right? So the NEET PG marathon that we did. So what is this? And these are all covered in your DVT, LRR and obviously in your notes. Okay, so this is a method to deliver what? Yes, extended arms. So can you tell me what maneuver is this? Especially मैंने ऐसे सिखाया था where you are holding the baby and you're rotating the baby first to one side and then to the other side. Yes, this is the Lovset maneuver, which is what we do to deliver a breech baby with extended arms. The image was not of Peanuts. Okay, Peanuts is incorrect, which is to deliver extended legs. Okay, the image was of Lovset's maneuver. Burns-Marshall is for the delivery of after coming head. Okay, and so is MSV. This is also for the delivery of after coming head, right? Okay, let's look at the third image. The third image was also covered by Dr. Sumer, but I have tried to get the closest possible image to the one that you got in your exam. So this was an MRI image. It was a 40 or maybe something like 32-year-old female with abdominal pain, right, as one of the complaints. And this is the closest MRI image that I could get after talking to lots and lots of students, right? So yes, the answer is adenomyosis. So remember, we have said that although the investigation of choice for adenomyosis is ultrasound, transvaginal ultrasound, but the gold standard, no, it was not an image of fibroid. Okay, so the gold standard is MRI. You know, typically when your diagnosis is doubtful, then yes, we do need an MRI, and especially when there is a focal adenomyosis. Yes, adenomyosis is usually going to affect the entire myometrium, but sometimes there is an entity which is called as focal adenomyosis, which I have also taught in the class, that especially in focal adenomyosis you need an MRI to differentiate it from fibroid uterus, right? So this is very typically an image of adenomyosis. I know that in your image, along with this in the endometrium, they had written ET also, right? But this, as I said, you will agree, is the closest image to what you got in the exam, right? देखो फाइब्रॉइड के लिए MRI ज़्यादातर हमें ज़रूरत नहीं पड़ता. Sometimes yes, we do an MRI guided HIFU. If you have attended my classes, then this is what we teach you. MRI guided HIFU होता है, high intensity focused ultrasound, which is done under MRI guidance. Then sometimes when there are multiple fibroids, preoperatively you want to do a MRI, but other than that, MRI is not routinely required for fibroid uterus, but yes, it will be required a lot of times in adenomyosis when the diagnosis is doubtful. So do you all agree that this is quite close to the image that you got in your real exam? Yes. Okay. So then let's look at the next question. There was a lady who is 65 years old. She has come with postmenopausal bleeding, right? And they had shown you, or with history of bleeding, and they had shown you a hysterectomy specimen. Now, very classically from the recall, what I got was that there was a hysterectomy specimen where the endometrium looked fragile or necrotic or dirty looking endometrium, and the adnexa is also shown. So if you agree, this is again very close to the real image you got. Also, हमेशा मैंने आपको क्लास में भी सिखाया है, whenever you talk about postmenopausal bleeding, what have I told you? That you should always rule out endometrial cancer, right? So endo CA हमेशा rule out करना चाहिए, and yes, this is actually a specimen for endometrial cancer, right? Okay, let's go on to the next one. The next question said there is a 35-year-old lady with very high FSH as well as LH values and very low AMH values, right? So AMH was around 0.05, right? FSH was, I think, as high as 50 international units. Okay, and when we talk about high LH and FSH, right, and very low AMH values, you all know we are talking about POI, primary ovarian insufficiency. I have told you that this is the new name for premature menopause or premature ovarian failure, right? So now we actually call it as POI, primary ovarian insufficiency. Okay, so please remember the reason is because there is no negative feedback, the gonadotropin levels begin to increase, which is what you also see in menopause. Okay, so premature ovarian failure or premature menopause. Okay, right. So this is the answer to this question. They all mean the same thing. Yes, a 35-year-old lady, okay, they are saying there was also history of secondary amenorrhea. Fair enough. So there is a history of secondary amenorrhea. You all know the answer is not PCOS, because in PCOS, LH can be high, मगर FSH normal होता है. Calmans में LH, FSH बहुत low होंगे. Hypothyroidism typically will not have a strong association, but yes, sometimes it can be associated with low levels of, again, LH and FSH. Okay. Let's look at the next question. So number of arteries and veins in the umbilical cord. Okay, so again, in your LRR, I did specify that some basics of placenta are always asked. That's what we covered in live rapid revision as well, right? So it could be this, it could be weight of the placenta, it could be ratios, it could be anything. So yes, it is 2 arteries and 1 vein. I hope you have not done a silly mistake on this one. And which vein is this? It is the left umbilical vein. Do you remember how we remember it? The left one is left behind, right? So it is going to be the left umbilical vein, and there are going to be 2 umbilical arteries, right? Okay, let's look at the next one. So there was a question where a lady has come to the doctor and she is showing linea nigra, engorged breast with Montgomery tubercles, and on examination it was very clearly seen that the uterus is enlarged and the doctor finds bluish discoloration of vagina. I agree that linea nigra and engorged breasts or Montgomery tubercles can be presumptive signs, but once she has come to the doctor, we have done the examination, it is no longer a presumptive diagnosis, it is now a probable diagnosis, because now the doctor has seen the changes. Both uterine enlargement and bluish discoloration of vagina, which is the Chadwick sign. Okay, they are considered as probable signs. So enlargement of the uterus, Chadwick's sign, they are both probable signs. So as and when a doctor has examined, pregnancy is now not a presumptive thing here. Now it is becoming a probable thing. As far as positive signs are concerned, I hope you remember, you can see fetal parts on ultrasound, right? Or you could see fetal cardiac activity on ultrasound, or in later pregnancy, you can feel the fetal parts on a PA examination, or you can even auscultate the fetal heart rate, but these two will happen later, right? Again, if you remember in my marathon session, the first slide itself, I had shown you the probable signs and I said that it will be asked in the exam. So if you go back to NEET PG marathon, this is the first slide that I started with, right? The Chadwicks, especially the Chadwicks and the Hagars, both of which can be seen as early as 6 weeks. Yes, the Chadwick sign can also be called as the Jacques-Mears sign. Okay, very nice. आगे बढ़ते हैं. Then there was a question that your patient is a post-LSCS patient. She has a BMI of more than 35. What will you give for thromboprophylaxis? Now, yes, so as per the guidelines, both American guidelines, Royal College guidelines and Foxy guidelines, if you are doing an emergency cesarean section, and the BMI of the patient is more than 35, then we should give her thromboprophylaxis for at least 10 days. If she has more risk factors, then we can give it for a prolonged period of time, which is 6 weeks as well. And again, there is a direct snapshot in the purpurium topic when I am teaching you about thrombosis of the pelvic veins or thrombophlebitis. I have taught you that whenever it is pregnancy or purpurium and we have to give thromboprophylaxis or treat DVT, deep vein thrombosis, it will always be low molecular weight heparin. Warfarin मैंने बहुत अच्छे से पढ़ाया है, that is approved only for one condition in pregnancy. Otherwise, warfarin is a category X drug. The only thing that it is approved for is, yes, prosthetic heart valves. Okay, and please remember, warfarin ka, there is a delay in the onset of action. Do you know that pharmacology? Yes, so there is a delay in the onset of action of warfarin. So when you have to begin anticoagulation, purpurium is a very strongly thrombogenic state. So the preferred drug is low molecular weight heparin, right? As I said, the criteria is emergency cesarean and a BMI more than 35. Then thromboprophylaxis will be done for at least 10 days. If she has additional risk factors like previous history of thrombosis or anything like that, then we might have to do it for a prolonged span, which is like 6 weeks. Okay. Let's go on to the next question. A patient after vaginal delivery is having postpartum hemorrhage. She continues to bleed even after the medical management. What will you do next in the labor room? Now, you got a very similar question in the FMG exam, but how was it different? In the FMG exam, they had asked about failed medical management and you are doing a cesarean section, which means you are already in OT, the uterus is open. Here, they have asked you failed medical management, but the patient is still in the labor room. So, what are you going to do? Yes. The answer has to be a balloon tamponade. So if you go back to the algorithms that I have taught, I have told you, you give oxytocin, and if the patient continues to bleed after oxytocin, what have I taught you? I have taught you, then in the next step, you will add more uterotonics, and along with uterotonics, you have to now add balloon tamponade, right? So the Bakri balloon tamponade, okay? No, compression sutures, okay, B-Lynch is a type of compression sutures. But compression sutures are not applied in labor room, beta. The compression suture is a surgical management which you will do after balloon tamponade provided the vitals are stable. So after balloon tamponade, if vitals are stable, we do B-Lynch. If vitals are unstable, we will go on to stepwise devascularization. Okay. Yes, B Lynch beta ji compression suture ka hi naam hai. Maybe they had given compression suture in the language, but they mean the same. The answer is still balloon tamponade. Okay. Let's look at the next one. So your patient is 9 weeks pregnant. She has history of toxoplasma 5 years back. Okay. Right? So toxoplasma kab hua? 5 years back hua. And now there is a positive IgG in the maternal serum and she is currently 9 weeks pregnant. Again, whenever I teach infections, I have taught you that you do not have to worry about IgG. IgG means a past infection, not a currently active infection. वो भी कब हुआ था? 5 साल पहले. So what is the suggestion or advice that you will give to the patient? You advise to continue the pregnancy as there is no risk, right? Please, this is not an indication for MTP. There is no need to start treatment for toxoplasmosis. It is a past infection. We will not directly do a invasive procedure like amniotic fluid assessment, especially when it is a past infection. Had it been a new infection for the patient, we can think of doing amniotic fluid assessment. Why is it done? To see whether the baby is also infected or not. But amniotic fluid assessment may be, we do not do what? We do not do it at 9 weeks. It is something which is planned beyond 15 weeks. It doesn't matter what else they write, right? The thing is, they have very clearly given you IgG positive, which means it is a past infection, okay? They've also written 5 years back. So the problem is, I've always taught you that you have to pick up the keywords and you have to integrate them, right? Also, I've taught you to go with your first instincts. If you think too much, you land up with overthinking and doing easy questions wrong. Okay. So, it is not important. IgG means it is a past infection. Okay. Okay. A lady has come at 36 weeks with reduced fetal movements. An NST is done and it shows 1 acceleration in 20 minutes. Exactly like this, I teach the case scenario when I do the classes with you, right? That a lady has come with reduced movements, you do NST. If the NST is showing 1 acceleration or 0 acceleration in 20 minutes, what do? You have to extend it for another 20 minutes. You cannot call it non-reactive before 40 minutes. So, answer is continue the NST for up to 40 minutes. Yes. Once you have reached 40 minutes, if there are less than 2 accelerations, it may be 1, it may be 0. So, if there are less than 2 accelerations in 40 minutes, then yes, we call it as non-reactive or we call it as a positive NST and we will go ahead and do a biophysical profile for the patient, but not in this patient. Okay, in this patient, it is continue the NST for 40 minutes. Okay. Okay, this is an image which was given to you. Diagnosis was asked again directly from my class. Whenever I teach you amniotic fluid, I teach amniotic band syndrome. Okay, in the history they had given there is absent index finger and I know that there was a collage of images, but one of the images was definitely this one. Do you all agree? So, one of the images was definitely the one that I have shown here, which is showing you constriction rings. Okay, these are constriction rings and absent index finger, where we tell you that the distal phalanxes or phalanges may get amputated, right? So, the answer is amniotic band syndrome, which is seen with severe oligohydramnios. Okay. Clubfoot can be a manifestation of this, or it can be a manifestation of any other syndrome. It is not the diagnosis by itself here. Arthrogryposis multiplex congenita is a condition where you see, problems only in the joints. You see joint contractures. So, here it is not just joint problem, it is constriction rings, typically the distal parts of the upper limbs and the lower limbs. Okay, so this is not B. Yes, in one hand, index finger was gone. Exactly. Images were of constriction rings. Yes, the answer is amniotic band syndrome. Let me ask someone. If you have attended my class, can you tell me what is the other name for amniotic band syndrome? I have taught you. We also call it as Streeter's syndrome, right? Streeter's syndrome. So, amniotic band syndrome and Streeter's syndrome are same. Okay? Chalo. Order of repair of episiotomy. So, it has to be first the mucosa. Sorry, it has not C option. Okay, it has to be first the mucosa, then it has to be the perineal muscles, and then it has to be the skin, right? So, mucosa, muscle and skin. Episiotomy corresponds to a second degree perineal tear, and we have also taught you which muscles are cut. Okay, so I told you arthrogryposis is joint contractures. You don't see amputations there and you don't see constriction rings. Okay, arthrogryposis congenita multiplexa is joint contractures, bache. Okay, multiple joints are involved there. Okay, chalo. This was the next question. Again, exactly the case scenario like we do in class. Your patient is 5 centimeters dilated, there is vertex, and she develops a cord prolapse. The question very clearly mentioned that there are cord pulsations are present. What is the management? So, if you go to my class notes or if you go to my live rapid revision notes, you will see exactly the same order in which you see the things here. So, what are you supposed to do? You are supposed to do a buttock lift, push the head up, which means you are supposed to put your hand inside and with your fingers you are supposed to push the presenting part upwards so that it does not compress the cord. This is the first and the most important thing to be done. Okay, you push up the presenting part, and for the same reason you also do a retrograde filling of the bladder, because once the bladder is full, it is going to push the presenting part up and the cord will no longer be compressed. So, exactly in the same order, I have also shared the images of the notes itself directly, right? So, this is the answer. Buttock lift, push up the presenting part or push up the head and do a retrograde filling of the bladder. And at the same time, while you are doing all this, you have to shift her to OT for an emergency cesarean section. Okay. Let's look at the next. Again, almost everything if you see has been covered in your revision resources. So, whether it is DVT or live rapid revision, it covered each and every MCQ of Obs and Gynae. Okay, hydroureteronephrosis is stage 3B, right? So, especially I tell you that it reaches the ureter. I also told you that it can also reach the pelvic side walls. So, if it reaches the pelvic side walls, it is again considered as 3B, and once there is involvement of ureter, eventually it can cause involvement of the kidneys as well. So, you will see hydronephrosis. And another related MCQ is, what is the most common cause of death in CA cervix? So, most common cause of death in cancer cervix, yes, is uremia. The reason for uremia is renal failure, because the back pressure changes continuously are affecting the kidneys, and as a result the kidneys eventually fail. Okay, so this is going to be stage 3B. Okay, all right, let's look at the next one. A 46-year-old woman with irregular bleeding, right, and endometrial thickness is given as 16 mm, right? What is the next step? Always I have taught in my class that if your patient is beyond 45 years of age and she has abnormal bleeding, especially in the form of menorrhagia or irregular bleeding, we must do a endometrial biopsy. I have also told you that they will ask what devices you need. So, NESET is very fond of asking what device will you use for this endometrial biopsy. So, like you can use a Pipil device, In India, we also use a Carman's cannula, right? Exactly what we are doing is endometrial aspiration cytology, EAC, but practically we call it as an endometrial biopsy. Pap smear should also be done. If she has not undergone any kind of screening so far, we will also do the pap smear, but pap smear right now is not the most relevant next step. The most relevant next step is endometrial sampling, right? Very good. Chalo, आगे बढ़ते हैं. There was a question which you all have been fighting it out for. A 65-year-old postmenopausal woman has come. Okay, her BP is 170/100, but she has come to you with blood-stained discharge, and you all are telling me I should send her to a cardiologist. Why? Do you think I cannot give her a tablet for high blood pressure? So, you know, she's come to a doctor and you think that I will not take care of anything and just simply send her off to a cardiologist. Please remember, 65 years of age, post-menopausal bleeding, there is a very high risk of malignancy, right? So, I will definitely do a pelvic examination. This was what was in your option. We will definitely do a pelvic examination and send a pap smear. वैसे भी, as age increases, you are likely to have slightly blood pressure on the higher side, right? So, if required, we will see what she needs an evaluation. But as of now, I am not just going to not do anything about the vaginal bleeding and just send her off to a cardiologist, okay? No, that is not the most relevant next step for her, okay? And especially only for high blood pressure, I really don't need to send her to a cardiologist, okay? So, please remember this, okay? Hypertension, I hope you know, is hypertension, diabetes, obesity. Do you know this? That these are risk factors for endometrial cancer. What do you call it? Corpus cancer syndrome. So, not only will I do a pelvic exam and pap smear, I will also try and do an ultrasound to look for endometrial thickness, do an endometrial sampling as well, okay? So, please remember this, they are risk factors, okay? Chalo. Then there was a question where we have asked you sequence of maneuvers in shoulder dystocia. I don't think the options were difficult because there was only one option जिसमें शुरू में McRoberts था और end में Zavanelli था, right? So please remember, McRoberts has to come first, Zavanelli has to come last, right? So they had jumbled up these 4 maneuvers. What were the 4 maneuvers? McRoberts, Gaskin, Rubin's and Zavanelli's, right? So the key thing is McRoberts is the first maneuver, Zavanelli's is the last maneuver, right? Rubin or Gaskin को कुछ भी पहले इधर उधर दिया था, it doesn't really matter as far as this MCQ is concerned, right? Again, something that I have predicted, even when we were doing the mock paper, NEET PG mock, you remember I had given a question on shoulder dystocia and specially I asked you, yes, that's okay, you can put Rubin here and Gaskin here, it's okay, the answer will still remain the same because as I said, there was only one option where McRoberts was first and Zavanelli's was last, okay? So please remember this. अगर आपको याद हो हमने NEET PG mock में मैंने एक क्वेश्चन दिया था आपको जिसमें I confused you about the finer details. You remember this? कि delivery of posterior arm पहले होगा या Rubin's पहले होगा? Do you all remember that question? So that was from your last NEET PG mock that we did, right? So I knew that they are going to give you these topics. They are not going to ask you something out of an encyclopedia. They will ask you basics, but they will twist options. They will make the options very close, and that is why you have to have a very good content and application of your content, right? So, yes. So, this was the answer for the shoulder dystocia question. Okay, chalo. Then there was history of prolapse and which ligament is damaged or which ligament is the best support was asked, right? So the answer is McEnroe, which I hope you also know is called as transverse cervical ligament. It is also called as cardinal ligament, right? So they are names of the same ligament, and especially when I teach, I tell you this, that you know, if they have to confuse you with this ligament, they will ask you other names in the option. So you have to know that they are names of the same ligament. Round ligament is not a main support. It is a support but not a main support. Yes, it is responsible for anteversion and anti-flexion. Broad ligament is not a support at all. It is a false name. It's not a ligament. Sacrospinous is not the ligament for uterine support. Okay, sacrospinous का क्या importance होता है? Pudendal nerve block. When you are giving a pudendal nerve block, you have to pierce the sacrospinous ligament. That's what they will ask you. They will ask you, if you are giving a pudendal nerve block, which ligament will you pierce? Then the answer is sacrospinous. Okay, chalo. Then there was a clinical vignette, again something that I have been putting in your CBTs and your mock test papers and always asking you to differentiate it from abruption. So the key words here were a patient of previous cesarean, she is in active labor, but the other keywords given to you were fetal bradycardia and maternal tachycardia. So these are signs of impending rupture, right? So these are signs of impending rupture. If you go to the topic of previous cesarean and back to basics, you know, I have very clearly written what is the first sign or symptom of rupture uterus or impending rupture. It is non-reassuring fetal heart rate. It is also the most reliable sign. It is also the first sign. So because we are anticipating an impending rupture, what is the step? I have written there that the management is going to be an emergency cesarean. हो सकता है at the time of cesarean, you realize that it is already a scar dehiscence, but that is an intraoperative finding, right? So the answer here is going to be the management is emergency cesarean section. Okay, let's look at the next one. The next question is a woman who has a 28-day and a regular cycle. On day 21 to 25 or day 1 to 24, whatever they had given, it doesn't matter. 24 दिया था या 25 दिया था, right? What is the correct status of her hormones? Again, go to your DVT, go to your classes, go to LRR. Do you remember a diagram that I have made you draw? Anybody remembers? And I've specially taught you that you have to see these diagrams and you have to know what is the interpretation of these diagrams, right? Do you remember this diagram? And if you have attended my class, you will know how I teach. Yes? Tell me. So I have taught you that there are two hormones which show you a peak, okay, in the second half. What are the two hormones? There is estrogen and progesterone. क्योंकि corpus luteum not only secretes progesterone, it also secretes estrogen. But the most important thing, और ये मैं class में भी पढ़ाती हूँ, what happens to LH and FSH levels? Yes, what happens to LH and FSH levels in the luteal phase? So you have to know that luteal phase में you see the lowest levels of LH and FSH. As far as the recall I have, there was only one option with where both LH and FSH were low, and that is the answer, right? So let's look at this. So as I said, LH and FSH have to be low, low LH, low FSH, and progesterone has to be high. ये तो mandatory है for the hormonal profile in this second half, right? So there was only one option जिसमें दोनों LH, FSH low थे, एक ही था. और अगर आपको ये आता था, आप DBT खोल के देखोगे, ये ग्राफ है वहाँ पे, Tab, you know, you were wondering why ma'am is teaching us the graph, because I knew they will ask you and they will confuse you in basics by making the options close, right? So remember, it is not about weird things. It is not about encyclopedias. It is about basics, concepts and application of concepts. That is what we all have to target, whether it is FMG exam or NEET PG or INISET, they're all going on the same lines. Okay, so the answer here is B as per the recall that I have got from the students. High estrogen and high progesterone, whereas low LH and low FSH. Okay, is that clear to understand? So I think I've got exactly correct recall because I've asked a lot of students for the recall. Some of you, you know, you want to sometimes keep thinking about it and people will twist. Believe me, if you see recalls from the YouTube, a lot of times people are twisting options just to prove themselves right. Okay, so please ensure that we have the correct recalls, because ab jo ho gaya, but any which ways, you know, these recalls are more for students who are going to appear next year in the exams, because they should know what is right. Okay, estrogen बहुत low नहीं होता बेटा. I just told you corpus luteum is going to secrete estrogen as well. So the three most important things are, number one, there has to be high progesterone, that is the important part in the second half, low LH and low FSH. In case there were two options with low LH and FSH, you have to go with one with high progesterone. Okay, very, very important. Okay, high progesterone and low LH and FSH, ये तीनों तो बहुत ज़रूरी बातें हैं. You will have to go with one which has these findings. Okay. Next, a 20-year-old woman with irregular cycles conceived with IVF. She has 2 months of amenorrhea and LMP is not known. What is the best parameter to know the gestational age? So the answer is going to be crown rump length. So again, covered everywhere, DVT, LRR and obviously your notes. That CRL हम कब use करते हैं? When I have written 3 things for you. I have written number 1, patient has irregular cycles. Number 2, LMP is not known. Number 3, patient has conceived on OCPs. In these 3 conditions, we cannot use LMP and therefore we will use crown rump length. Not just that, if you remember, I've taught you what is the ideal time to measure crown rump length? 7 to 9 weeks, right? 7 to 9 weeks is the ideal time to measure crown rump length. Okay. Chalo. Loading dose of MagSulf. Again, people who are teaching superficially, then you might have done this incorrect. Okay, but please remember they have asked loading dose of MagSulf as per the Pritchard's regime, and the answer is not 4 grams, it is not 10 grams, it is 14 grams. You have to know this 4 grams is given IV and along with this 10 grams is given IM. The total dose of MagSulf as per the Pritchard's regime is 14 grams, exactly same way we have written in DVT. Loading dose is 4 grams IV plus 10 grams IM. So a total of 14 grams. Okay, that is the answer. So it's not 4 and it is not 10. Okay, so this is as per the Pritchard's regime. Okay, then there was a question on ovarian tumor. Again, directly we have done this when we have done this in your marathon as well. So if you remember in the NEET PG marathon, I just did images for you, and out of I think 5 or 6 images, except for the MRI one, all the images are from the marathon session, right? So this is ovarian tumor. What were the hints? If you go to the marathon, you will see that I had written the hints on the basis of which you will mark the answer. The hints were raised CA 125, ascites and papillary excrescences, right? So when you have the papillary excrescences, you have raised CA125 and the cancer has already spread causing ascites. This is a typical serous cyst adenocarcinoma, right? Yes, it can be multiloculated. It is a complex mass, okay? Because it is a malignancy, it's a complex mass. There will be solid areas, there may be cystic areas, okay? So please remember, the answer is serous cyst adenocarcinoma. Yes, it is not an endodermal sinus tumor. Endodermal sinus tumor is same as yolk sac tumor, and yes, uska tumor marker hota hai alpha fetoprotein. Okay, in every CBT and the mock test, right, we gave this as a MCQ. Kisi mein we gave you the tumor markers, kisi mein we gave you these keywords, ki kaun se tumor mein kaun sa keyword used hota hai, right? That brings us to the last question. Again, directly from DVT, verbatim, there is a line there. So, what is the reason for amenorrhea because of high prolactin? Very similar to why we see lactational amenorrhea. So, the reason for amenorrhea is negative feedback of prolactin on GnRH. So, it inhibits GnRH. As a result, there will be low pulses of LH and FSH. So, no, the reason is not increased A2. In fact, it will be decreased. Okay. Pulsatile release of FSH or LH kam ho jata hai. And as I said, LH, FSH levels are going to be low because there is a negative feedback on GnRH. So, that is the answer for these 25 questions. I hope I haven't missed any MCQ, right? So, do let me know how you have performed. I hope OBGY was a scoring subject for you. We've tried our best to give you whatever best we can, whether it is in the form of revision courses or it is your back to basic videos or it is your CBTs and mock test papers. So, I wish each one of you all the best. May you come out with flying colors and you do well, and most importantly, you get the branch of your choice. So, take care everyone, all the best to each and every student for your results, whether it is our FMG students or whether it is our NEET PG students. Both of you are waiting for results. So, God bless you, and I will pray that you are blessed with success and the branch of your choice. Okay, so take care everyone, all the best. Keep doing great work.